Hello, good evening. My name is Zalapo. Welcome to my YouTube channel. So today I am going to be talking about trauma and suicide. So just a warning that this video is about, I'm talking about mental health, trauma, and suicide. So there's going to be warning. So yeah, warning because I'm talking about suicide. So if this video is for you, or you want to learn more about the relationship between trauma and suicidality, this video is for you. If you're supporting a family member that is having mental health distress, this video is for you. And if you're working with clients, if you're working in mental health and addictions, or you're a nurse working in community mental health, this video is for you as well. So you don't have to watch it in one sitting. You can always pause it, take a break, and then continue. Okay. So as you guys all know, that September is Suicide Prevention Awareness Month. What I say? So September is Suicide Prevention Awareness Month. So basically, it's like a national day, national month for suicide prevention. Just to it's and I think for this year it's focusing on stigma, because of the stigma that surrounds mental health itself. So there's still a lot of problem in terms of stigma, that people can't talk about their mental health distress because of they are afraid of being judged, or they are afraid of being labeled as crazy, or seeking attention, or other things. So because of that, they keep silent, and then they die, or they struggle in their silence. So for today, I am going to be talking about trauma and suicide, and a lot of things. I'm going to be pulling it from the Center for Suicide Prevention. I am going to put the website on my video description, so that you can also look at the resources at your own time. You can share it with your clients, with your family members, and you can also read it yourself to get informed. Okay, so what is like trauma? So trauma affects anybody. It affects. It doesn't have to. It is not discriminating like age, or race, or gender, or sexuality. It can affect anyone. It can affect either you're in Canada, either you're in developed country or not. Trauma can affect anybody at one point. At one point in their life. Okay, so I'm just going to be flipping over my notes just so I'm not going off topic. Yeah. So again, I'm going to focus on trauma and suicide. So what is trauma to you? Like, what does it mean when I say trauma? Emotional trauma is not like physical trauma. Like, for example, you fell down and then you scrape your skin, or you bruised your toe, or you bruised your wrist, and then it started bleeding. That one is physical trauma. But when I'm talking about trauma and suicide, I'm talking about emotional, psychiatric trauma. So let us start with what is trauma. So I'm going to use the definition of Greenwald. It's an article that was written in 2007 by Greenwald, and also the definition is on the website of Center for Suicide Prevention website, which I'm going to leave the link below. Trauma is a horrific event beyond the scope of normal human experience. So it is a horrific. So I want you to like horrific is horrible. Horrific experience beyond scope of normal human experience. So an example of trauma can be like motor vehicle collision, or you are a witness to like a murder scene, or homicide scene, or you are a witness to a completed suicide, for example, is an example of traumatic experience. It can be like, for example, the what do they call them, the people usually go for wars, who like combat, right? They can like they can shoot, they can be shot. Other soldiers can see their members being shot. So that is an example of traumatic experience. So, for example, rape can be a traumatic experience, neglect and abuse, emotional abuse, physical abuse can be an example of traumatic experience, and losing a loved one can be a traumatic experience. Childhood abuse and neglect can be a trauma. Separation, parental separation and divorce can be a traumatic experience. And the thing about trauma is that there's no like one yeah, one thing fit all. Like, there's not like a formula for dealing with trauma. Like the treatment for trauma, it's probably targeted towards the symptoms. For example, if you are having PTSD, you are having difficulty sleeping, they will try to make, like treat the symptoms of inability to sleep. Or if you're having like, if you're experiencing depression, they will try to treat the depression. Or you can also use medication. They use medication, combination of therapy, so psychoeducation, psychotherapy, pharmacotherapy, combination of treatment can be used for people who are diagnosed with post-traumatic experience, which is called PTSD. It's not everybody that has traumatic experience that is diagnosed with PTSD. And if you are not diagnosed with PTSD, that does not mean you are not struggling. Okay, that does not mean you can't get help. It's just that some people may be diagnosed, some people may not be diagnosed, but they know that they have traumatic, they have post-trauma PTSD. So I'm just going to read some statistics and facts. So in the United States, the majority of clients who end up in human services system are trauma survivors. So that's Elliot, 2005, Elliot and colleague. Also, in Canada, 75% have experienced, so that is 75% of the population. That is a lot. 75% of the populations have at least experienced one traumatic experience in their lifetimes. So that one is Clinic 2013. So the percentage of survival of sexual and physical violence in Canada is high. Of course, domestic abuse can also be a traumatic experience. So 50% of those is women, and 33% of those impact men. So trauma can affect any gender. It can affect women, male, LGBT. It can affect anybody. It can affect children. Childhood trauma, for example, people can carry it on to adulthood. They can take it into adolescence, and then they can carry it forward into their adulthood, and then it keep going, the cycle keep going and going and going. So that is why it's important for people to actually figure out, try to find what is going to help them with their trauma so that they are not alone. Okay. This is some effect of trauma. So it can be alcoholism, for example. The person will try to be coping by drinking, and then because they are using alcohol to cope, it can lead to long-term use of alcohol, which can now lead to addiction. Depression, right? So that is like feeling of helplessness and sadness. So sadness, like depression, because sadness is different from depression. They don't have like they feel like they are worthless. There's no reason for living. They don't have have intent on living. They don't have any meaning to life, or they are not finding joy in the things that they used to enjoy before. Those are the symptoms of some symptoms of depression. Insomnia, difficulty sleeping, suicide attempts, those are the complications of trauma. So suicide attempt means the person is attempting to kill themselves. So it can either be completed, or it can be uncompleted. Okay. Also, complication can be people who actually die by suicide. Can be a complication from trauma if they didn't get help. Relationship problem, for example, like separation, marriage breakup, and divorce, boyfriend, girlfriend, romantic relationship breakups too, can also be a major complication, like complication, um, effect of trauma, can cause trauma. uh, so these are symptoms of trauma. So disconnection from self. For example, you feel like this is not you anymore. You don't understand yourself. The second one is emotional numbing. So maybe you don't know what you're feeling. You don't know if you're feeling happy or you're sad. Um, if somebody asks you how are you feeling, you say like I don't know, like I don't know. So that's an example of emotional numbing, including drinking alcohol or drug use. You are hyper aware of your surroundings, so you are like hyper vigilant, looking if something bad is going to happen. That is a symptoms of trauma. So memories or flashbacks of the event. For example, if somebody was raped, they can have like memory and flashbacks of the incident, how it happened, and it's or they can even have nightmare of the traumatic experience. Another common one is self-blame. You'll be blaming yourself, or you're blaming blaming other people, or self-guilt. You feel like you are the cause of that traumatic experience, for example rape, or maybe like it is neglect or it is abuse. You start to blame yourself, or or you start to blame other people. um there's loss of interest in activity. So for example, if you used to love basketball, or you used to like singing in the church, or going into different social activities, you tend to isolate yourself. You don't enjoy those things that you used to do before, which is also a sign of depression. um Aggressive or risk-taking behavior, for example drug using. You are trying to take risk. Impulsive behavior can also be an example. Change in sleep habits can also be a symptom of trauma. Again, the symptom of trauma is different from one person to the other. So this is just common symptoms that was listed by Center for Suicide Prevention. um there's two disorder that is associated with trauma. The first one is acute stress disorder, ASD, and the second one is post-traumatic stress disorder, PTSD. So acute stress disorder may be like, for example, the initial response to a traumatic event. For example, let's say you witness like a car collision, like you're like, or that shock, that initial shock of what you witness. That is an example of acute stress disorder. um so it can be the symptoms can be similar to what I've listed in the past, like trouble sleeping, self-blame. You think that you are the fault why the accident happened. You constantly think about the incident for couple days, you know which can cause insomnia. The second one is PTSD, post-traumatic stress disorder, which is kind of like a more serious disorder than the ASD, than the acute stress disorder. Um, so symptoms of ASD and PTSD may trigger other disorders such as substance use, anxiety, depression, low self-esteem, personality disorder, and eating disorder. So for acute stress disorder, uh, you know, the symptoms will go on for like a month, where you are constantly blaming yourself for the incidents. There's disconnection from yourself, change in sleep habits, risk-taking behavior, using substance, or whatnot. Why post-traumatic stress disorder, it goes on for more than 1 month, if that makes sense. It goes on for more than 1 month. Yeah. So then the next thing I'm going to talk about is who is at risk of trauma. Who is at risk of trauma? So people with poor health or deteriorating health. So for example, it can be physical health and it can be mental health. So let's say somebody got a diagnosis of cancer, um, you know, or maybe it can be a loved one that has that diagnosis and the prognosis is not good. That is poor physical health, right? For mental health, for example, if somebody has depression or and they have a lot of contributing factors, a lot of stressors that has contributed to their poor mental health, like multiple level, like family struggles or family dysfunction, diagnosis of mental illness, and they are using substance. So that is poor mental health. So it can also trigger um, suicidality as well. Uh, so the second one is people receiving ongoing medical treatment. So for example, I talked about it like cancer patients or psychiatric patients. They are at risk of trauma, they are at risk of suicide. And that is why when like I work in mental health, so when I have a new client coming to access mental health services or mental health and addiction services, one of the things that we do is called suicide risk assessment. And the reason why clinicians do suicide risk assessment is to know the baseline of the client, right? Sometimes clients come in to access mental health services with no suicidal ideation, so thought of suicide. And then when you are doing therapy with the client, they start to have suicidal thoughts, maybe because there's a new stressor in their life or they are not able to cope very well. So that is why it's important to do suicide risk assessment and reassessment. Um, Again, suicide risk assessment is not gonna give the clinician an idea that okay, this person is going to die by suicide on September 23rd. No, suicide risk assessment is basically to assess the client support system, know their suicide attempt history, if they are using substance, their ability to cope, their support system and stuff, and see if their risk level. So it helps the clinician to provide support based on the risk level. For example, if they are high risk, they may be like, maybe the client have suicide thoughts and suicide plan, and they have an history of suicide attempts, they are using drug, they live alone. So there's different level of risk, that's different information that will make you to assess the client as high risk or low risk or no risk at all, right? So depending on the discussion on your assessment, sometimes there may be, you may have to use the Mental Health Act, where the client is denying mental health services, but they want to kill themselves and they already have a plan to kill themselves like within the next few hours. So if they are wanting to not want admission, then that is where the mental health comes in. uh, I guess, yeah. So make sure that you go through your workplace policy if you are working in mental health, how to deal with suicide risk assessment, suicide safety plan, as well as providing support for the family and things like that. So homeless people are at risk of trauma, they are at risk of suicide because they don't even have a physical place to stay. So again, there's no support at all. They are like sleeping in different places every day, and at the same time they are struggling with their mental health. They have trauma. They are less likely to get help because of that additional barrier of being homeless. So they are at risk. Children are at risk. They depend on adults, right? Children depend on adults in terms of their need and their wants. And also children are more likely to be abused emotionally, physically, and sexually. So that is why they are at risk of neglect as well. Indigenous people are at risk of trauma and suicide. And the reason why they are is because, for example, the intergenerational trauma. Yeah, that's history of colonial history, residential school. They have history of being abused, the children. In the last couple months, you can see how in Canada they've been discovering children grave sites in all over different parts of Canada that has caused a new open, like, open wound of indigenous people who are still recovering from the trauma of losing their loved one, through the residential school and through the foster care system and stuff. So again, that is why indigenous people are at risk. Refugee is at risk of trauma and suicide. And the reason why refugee is at risk is because, like, refugees specifically come to Canada, maybe they are fleeing their original country due to war or unfair treatment, basic human rights, right? So they came here, they may have seen war, witnessed war, people being killed, or people being treated unfairly, or maybe they would have experienced a lot of emotional abuse themselves, that in terms of that. So they are at risk of experiencing traumatic experience. First responders are at risk of having trauma. So for example, paramedic, nurses, firefighters, you know police officers. They are first respond. They not even nurse, like paramedic, firefighters, and police. For example, if there's a shooting somewhere, the first people that they usually call is 911, right? 911 and the police and the fire department, they go there to the scene, and so they are at risk of experiencing of having trauma. Medical doctors as well, they had risk of having, experiencing trauma. I'm confusing myself with using this word. So what is trauma-informed care, or TIC? So healthcare professionals are more aware of effect of trauma than ever. And that is why it is important to talk about trauma-informed care. So trauma-informed care basically means treating a person, treating your patient, your client, your resident, treating them knowing that, for example, the risk of this person. If you're working with children, if you're working with all these people that are at risk, if you're working with indigenous people, if you're working with refugees, if you're working with people who, like, veterans who went to war, you should work with them with that thinking that they might have experienced some sort of trauma. For example, children who came to see a clinician, they said they want to talk to a clinician about some things they didn't talk to their family member. And so being careful of working with your clients that have been traumatized, and you don't want to re-traumatize them. So an example of trauma-informed care can be, if you're a psychotherapist and you are working with children who has been traumatized, maybe neglect or emotional abuse, or maybe it was a physical abuse, don't force your client to talk about their experience unless they are ready to talk about it. That is an example of trauma-informed care. And also the language that we use in communicating with our clients who have experienced trauma. For example, don't say what is wrong with you. Rather, you should say what has happened to you. And that was a question that was raised by an author named Rosenberg, 2011. What is wrong with you? It's a question that makes the client feel like something is wrong with them as a human being. What has happened to you, it's more narrative, like a story. It makes it more welcoming, that let them talk about their experience in a very safe environment without judgment. You can see the difference between that. Again, the way we talk and communicate with our clients, in a trauma-informed manner, it's very, very important to have a good professional relationship with the client, and it creates a space to be able to share, to be able to share, and also the relationship between the service user and the clinician. Yeah. So trauma informed care, it can be adopted in emergency room, it can be adopted in doctor's office, clinician's office, rehabilitation center, in psychiatry, counseling offices, private practice, focusing on people and meeting them at where they are at, and then working your way up, according to their own pace. So for example, if don't ever force a client to talk about their traumatic experience if they are not ready to talk about it. Give them that autonomy to go at the pace that they want to go. Those things, some of the traumatic experience that people go through, they are not easy to talk about. There are some things that you talk about and you start to cry. There are some things that you talk about that you will start to have the memory of the incident, right? Yeah, so basically, so being trauma informed means understanding the impact of trauma on people and the prevalence, right? It also means recognizing the signs of symptoms of traumatization, right? Or re-traumatization. So re-traumatization means, for example, maybe somebody has recovered from their trauma, and recovered, I mean, maybe they are moving on with life. That does not mean, it cannot take away the experience, but they were able to move on with their life, having good mental health, coping well with their past trauma. So re-traumatization may mean bringing back those experiences. So I'm going to give an example of re-traumatization. For example, in research, if you are doing research on trauma on participants, to ask about their experiences of racism or their experiences of rape or whatever, if it is a qualitative study, it's different. If it is a quantitative study where you have to interview, ask, like interview them of how about their experiences of rape, of course it's going to open some wounds, emotional wounds. They may cry, there may be a lot of reaction, because they have to flash back to those incidents, rewind it and talk about it. And so that is re-traumatization. So that is why it is important for researchers to provide support for their their participants, like counseling services, and making sure that when they are interviewing their participants, they make sure that they get, tell them, only say whatever you're comfortable saying in this research study, and you can also stop at any time you want. You can discontinue to be, you can discontinue to be a participant if you want. Those kind of things. You can't just interview client and say, yeah, we are done this research, bye. No. So that's why there's a lot of ethics committee when you particularly using human subjects for different sort of research. So being trauma informed means creating an environment that is emotionally and physically safe. Okay, emotionally and physically safe, to empower the individual who had experienced trauma, respecting the person, their rights, respecting their dignity, and respecting and listening to them with empathy, without judgment, right? Creating that space to share, right? To share and to validate their experience, to validate their feelings, right? That is what trauma informed care means. There's a lot of counseling, counselors, psychologists, clinicians, that focuses a lot of their counseling on trauma. So yeah, so so the next video I'm going to do is going to be focusing more on frequently asked questions about suicide and trauma. So I'm going to do a frequently asked question on suicide, then there's going to be another one on trauma, or maybe I'm going to do them together, I don't know yet. uh, but yeah, so that is basically it. The how trauma and suicide, how they are linked together. It's it can cause mental distress. Trauma can cause mental distress, and sometimes we all react to this, to emotional difficulties differently, because we all have different stressors, right? So for example, for person A, it may be a family issue coupled with family history of mental illness, or a personal diagnosis of mental illness. They are taking medication, they have substance use disorder. And person B has, maybe there's a loss in the family, right? And then they are having some, feeling of sadness, that grief, and so it's different from every one person to the other, and there's no like one size fits all approach. People use different approach in dealing with their trauma, in coping with their stresses, as well as different approaches to healing. For example, I said about medication is pharmacotherapy, and psychotherapy, counseling. Some people don't, it's not everybody that is struggling with their mental health that also see a mental health clinician. Sometimes we have family members who can do that for us. For example, if you have a supportive family, that they can be that role, to be your clinician, talk to you, listen to you, and without being judged. And yeah, that works as well. But if you feel like you're struggling with your mental health, your sleep pattern is different, you are not enjoying life, you feel like you're giving up on life, and you are better off dead than living, please, please, please don't. I understand that you're difficult emotion right now, but there's help out there. Make sure you look at resources in your local resources in your community. You can call 911 for help. In Saskatchewan, you can call 811, and you can ask to talk to a mental health clinician who will get you help. You can call your local crisis line as well, okay? And talk to friends that you trust, okay? There's some things that we don't have to pay for, right? Like friends, if you have good friends that you trust, and you have this good confidence in them, share how you're feeling, and they might be able to get you help, right? Mental health issue is real, suicide is real. Please take care out there. Yeah, until next time, thank you.